Yeah, thank you very much for the kind introduction and the invitation. For me, it's very early in the morning. I still suffer from the big time difference from the West Coast in the US and Europe. So I'm very sorry that I couldn't make the trip. I was traveling over the weekend and I just arrived back in the on the West Coast last evening. So I'm happy to join remotely, and I hope it's fine for everyone. So oops, need the pointer. So yeah, my project was about the gastrin-releasing peptide receptor ligands and potential beneficial effect of the terbium labeling and compared to the lutetium labeling. So I'm going to present some background first. The gastrin-releasing peptide receptor is a very old target, I would say, has been around for a very long time. It's overexpressed in prostate and breast cancer and some other cancers. So mostly it has been tested in prostate cancer so far. The most prominent member of the bombesin family is actually the gallium RM2. It shows very nice images in patients with the gallium. But for treatment, bombesins has always been a bit prone to enzymatic degradation. So the in vivo stability for treatment was never perfect, never ideal. And we thought a few years ago, so actually during my PhD, we thought that this could be due to a major cleavage site here between the glutamine and the tryptophan moiety. So this is present in all bombesin-related compounds, and most of the GRPR ligands are actually based on the natural bombesin. So this is a key problem in every bombesin-based ligand. So actually, we tried a lot during my PhD. So it took me like 3 years to find a suitable replacement which would not ruin the affinity completely, because I soon found out that if you change anything at the glutamine or tryptophan position, then you lose most of your affinity. So this was a big problem. And actually, the solution was just a tiny methyl group located here at the alpha carbon of the tryptophan moiety. So this did not affect the affinity, but it significantly affected the in vivo stability. So this was a very nice discovery back in the days when I was still in Munich in my PhD. And as you can see here, we had higher in vitro stability in human serum, but also in vivo stability in urine serum. And it also was cleared mostly intact. So in the urine, we could still find more than 70% intact for the AMTG, but for the RM2, it was less than 1%. So this was actually the data with which I applied for the PRISMAP project, I think 2.5 or 3 years ago. Very recently, we were able to confirm the high in vivo stability also in patients. So this is lutetium AMTG stability over time, so up to 6 hours in patients compared to the published data for RM2. And we could actually see and confirm that the in vivo stability is not just in the animal model, it's also the case in the human, for the human situation, which is of course very nice for us. But as I just explained, this data here, we didn't have it 3 years ago when we applied for the PRISMAP project. So we wanted to do, together with PRISMAP, we wanted to do terbium labeled compounds. So why terbium? Well, terbium is very interesting, I would say, especially at the moment, because it could actually be very similar to the lutetium 177, which is basically the most established radionuclide for treatment in nuclear medicine. So the terbium actually has the very similar physical properties to the lutetium 177, but as you all know, it emits more Auger and conversion electrons per decade than lutetium. And these Auger electrons have a very high linear energy transfer, so it could end up in being even more powerful for treatment of the tumors than just the beta particles. And as I explained, it's very similar to lutetium, so it has basically the same beta particles. So these Auger electrons are basically on top of the beta particles. So this combination could result in a better treatment efficacy than the lutetium, and that's why terbium is very interesting. The problem of these Auger electrons and conversion electrons is that they are very they have a very small range, so they have to get very close to the cell nucleus in order to inflict damage to the cells. So a combination with antagonists, which stay at the membrane, is not very smart, we all would think. But actually, Christina Miller's group proved the opposite. So a few years ago, they published this wonderful study of somatostatin antagonists compared with somatostatin agonists. So the DOTA LM3 is the antagonist, the DOTA TOC is the agonist. Again, it's somatostatin 2 receptor. It's another target than the GRPR, but they could prove that if they label their somatostatin antagonist with terbium and compare it to the terbium-labeled somatostatin agonist, the tumor control and overall survival is way better. So this was a very nice example of proving a lot of the assumptions that I guess we all had a few years ago wrong. So yeah, the authors explained in their paper that it's not actually clear what exactly happens at the membrane. And something must happen at the membrane or maybe through the membrane, but it's not actually clear what exactly happens. But they called it membrane effect, and I think we still have to find out what exactly these Auger electrons, when they are close to the membrane, because I mean the terbium is bound to the DOTA and the DOTA is bound to an antagonist. The antagonist stays mostly at the membrane, so something must happen at the membrane, which must be done by these Auger electrons. Because if you compare it to the lutetium-labeled antagonist, it's still a lot better, so significantly better treatment efficacy. So something must be done by these Auger electrons. So back 3 years ago, I knew, okay, I have a very good GRPR ligand. I have an antagonist, so why not try it with terbium as well for another target? So maybe it not only works for somatostatin 2 receptor, maybe it also works for other targets. So we had AMTG, we compared it to the reference RM2, which is basically an established GRPR ligand. So this was a nice comparison. Then we wanted to see, okay, if we label it with terbium, does it have similar or maybe even improved in vitro and in vivo properties than the lutetium-labeled compounds? And then we also wanted to do treatment efficacy and toxicity studies with these terbium-labeled and lutetium-labeled GRPR ligands. And we wanted to see if the terbium really leads to a better treatment efficacy because of these additional Auger electrons and the linear energy transfer. And of course, we also wanted to see if this higher in vivo stability that we have for AMTG also kind of improves the treatment stability. So this is the data we already published, and I think I presented this data 2 years ago when we had another PRISMAP event. So this is not our current data. So this data is already 2 years old, but it was interesting to see that the terbium-labeled compounds were actually quite similar to the lutetium-labeled compounds. So the affinity was slightly better, which was surprising, but I mean, I take it. The receptor bound fraction was similar to the lutetium-labeled compounds. The log-D was actually slightly more hydrophilic than the lutetium-labeled compounds, but not much. And there was no no effect actually in the in vivo stability. So similar in vivo stability for the terbium-labeled and lutetium-labeled compounds. Again, the in vivo stability is more it's mostly done by the compound itself. So AMTG showed higher stability than RM2, which was the case for terbium and lutetium. So the radionuclide didn't affect the in vivo stability. And this was our in vivo data from 2 years ago. So we could see that the terbium-labeled AMTG had the highest accumulation and retention in the tumor, followed by the lutetium AMTG, and then the terbium RM2 had a higher area under the curve than the lutetium RM2. But we also have to mention that the higher in vivo stability in animals led to a higher pancreatic uptake of the AMTG compounds compared to the RM2 compounds. So this was actually my data from 2 years ago when I was still doing my postdoc in Munich. And then I had a problem because I received the offer from Stanford University to join Stanford. This was a great honor for me, so I accepted. But I contacted PRISMAP immediately and told them, well, I will actually leave Munich and will go to the west coast of the US. So I guess this is it for the project. So I think I have nice data, but the treatment studies, I would have liked to do them, but I just don't have enough time. But this was a very nice moment because several members of PRISMAP told me, well, Thomas, you know, we can ship terbium around the world. We can also ship it to the west coast of the US. So why not try to continue the project at Stanford? So I spoke to a lot of persons at Stanford, and finally, after a few weeks or months of preparation and organization, we were able to receive the terbium. So thank you again, PRISMAP, and also the colleagues from Belgium for making it possible to fight all the odds with the custom clearance and all that stuff. So it was complicated to organize, but in the end, it was actually good that it worked. So when I started my project in Munich, I had never any labeling issues with terbium and not with the lutetium, so this was never a problem. But then when I tried the same at Stanford, the lutetium labeling worked fine, but the terbium labeling did not work as good as expected. So usually I always aim for 50 megabecquerel per nanomole of the precursor, which worked fine in Munich, but for some reason it didn't work in Stanford. So I reached out to the colleagues in Belgium. They actually suggested to prepare the solutions freshly and to also avoid any contact to metals. So I actually ordered a decapper. Didn't use any metal needles to get to or to draw the terbium solution. So it improved it a bit, but still not to a degree where I was happy. So I think I was able to label like 25 megabecquerel per nanomole, but not 50. And then I again have to, a big shout out actually to Uli Köster. So I reached out to Uli. I think you remember when I was kind of desperate because I wanted to do the project, but I was just not able to get to the 50 megabecquerel per nanomolar activity. And he actually sat down with me over Zoom. We kind of discussed everything I've done so far. And then he actually found the problem, I think. So he was kind of asking me, okay, how do you prepare your samples? So which spatula do you use? And I was like, okay, I'm using a metal spatula because I've always used this metal spatula. And he suggested, okay, just try it once for me without a metal spatula, and I did it, and he was right. It worked fine. So in the end, when I didn't use a metal spatula to just weigh in, the powder for the solutions, for the precursor solutions, it worked. So thank you, Uli. You kind of saved this project. So it was interesting to see because even Uli told me during our meeting there shouldn't be a big difference between terbium and lutetium labeling, but for some reason, maybe it's the west coast of the US, I don't know, because in Europe it was never a problem, but maybe on the west coast in the US, terbium is more sensitive towards metal contaminations than lutetium. Okay, so when that was done, I was finally able to start the treatment studies, which I wanted to do for a very long time. So we had PC3 tumor-bearing mice. We injected around 15 megabecquerels twice, so on day 0 and day 7 of the treatment study. And then we followed up on the tumor growth of these animals. So here you can clearly see that the terbium AMTG had the highest or best tumor control, followed actually by the terbium ARM2, and then there was the lutetium AMTG and lutetium ARM2, which also resulted in higher overall survival of these animal groups for the terbium-labeled ones compared to the lutetium-labeled ones. But we also could see that AMTG, when it's labeled with the same isotope, had a better tumor control and overall survival than the ARM2. So actually, we could prove what we wanted to prove, that terbium is more powerful for treatment than lutetium, but in vivo stability is also very important for higher treatment efficacy. So we also had to analyze the potential toxicity. So we did kind of the same treatment study, but this time in healthy animals, so they did not have any tumor. We carried out a total blood count, and also we asked the diagnostic lab to analyze the serum parameters, and here you can see serum parameters that would indicate a potential liver toxicity, but we did not see any signs of liver toxicity. So when you compare the control group, which did not receive any radioactivity, you can see no significant differences between the groups. We also did not see any differences in the blood urea nitrogen and the calcium, which would indicate potential kidney toxicity. We did not see any difference in total protein albumin, which would indicate potential malnutrition. So this was actually, as expected. We didn't expect actually any toxicity based on the low amount of activity we applied or we administered for these animals. We did not see any changes in erythrocytes. There was a trend for the leukocytes, but again, this was not significant. The only thing which was significant was the platelets, so the thrombocytes. So we had a higher thrombocyte count for the lutetium and terbium labeled compared to the control group. But I'm not sure if that is really treatment related. So this might also be an experimental issue. So we used EDTA coated vials, but maybe it was still not enough to prevent the coagulation. So maybe that was the reason, because usually, so I did some research. I'm currently writing the paper, and most of the time I read that the thrombocyte count could decrease by radiation therapies, but I didn't find anything on an increase in radiation by a radiation therapy. So I'm not sure. Maybe it's an experimental error. There was no significant difference in the hemoglobin count and also concentration, also not in the immature reticuloid fraction, which would indicate potential problems with the generation of the white blood cells by the bone marrow. So bone marrow should be fine. There was a trend in the lymphocyte concentration and also the neutrophils. So we could see that the groups that received radioactivity had a lower lymphocyte count than the control group. But again, lymphopenia is actually a known adverse event for radiation therapies. So usually these lymphocytes can recover over time, so this, it wasn't significant, even if it looks like a valid trend, maybe because we didn't use enough animals in order to get a better validation, higher valid result actually. So we also did analyze the kidney and the pancreas histologically, because pancreas is basically the organ at risk. It has a high GRPR expression, so we wanted to make sure that the pancreas was not affected, and we did not see any sign of toxicity between the control group and either of the treatment groups. Kidney is the clearance organ, so we always have to pay attention to the kidney. But again, for the kidney, we also didn't see any signs of toxicity. So at least not for the activity which we use for these treatment studies. So in the end, I'm pretty happy with the results. So we could see that terbium had a higher treatment efficacy than lutetium. We could see that the in vivo stability of AMTG is also beneficial for the treatment efficacy. So a combination of terbium and AMTG might be very interesting, not only for the animal model, but also for the human situation. We didn't see any toxicity, again, at the amount of activity we administered. So maybe there will be some toxicity when we administer higher activities, but this was actually not our goal. We wanted only to make use of these few batches we received from the PRISMAP. So we couldn't actually inject higher activities, or we couldn't fractionate it even more. So I think it would make sense to do fractionated administration of the radioligands, not only twice, but maybe for 6 times. So I have seen a nice publication of lutetium RM2 from 10 years ago, I think. They did up to over 100 megabecquerel of lutetium RM2 and over 6 injections. So they actually were able to cure some animals, which makes sense because it's a higher activity, but we just didn't have enough terbium and also not lutetium or resources to do this kind of treatment study. So we just did like 2 injections with this amount of activity I just showed you, so a total of 30 megabecquerel, and we did see what we wanted to see. So there is a valid indication that terbium AMTG might result in the best treatment efficacy also in the human situation. And this is actually the aim for the near future. So I would be interested in testing terbium AMTG in patients. I think most of you are, or maybe all of you are aware that in Germany we have the option to use our famous law actually. So we can maybe test in a proof of concept study, can maybe test the terbium AMTG also in prostate cancer patients and see if it results in maybe better treatment efficacy than the lutetium AMTG, which looks already pretty fine. The small problem with the whole study is that AMTG has been licensed by a big company. So this company also has their own interests. So we are actually talking to the company and trying to convince them to let us do the clinical translation of terbium AMTG just for a proof of concept. So we don't intend to replace lutetium AMTG by terbium AMTG. We just wanted to see if the terbium AMTG looks actually more promising than the lutetium AMTG. So I'm still working off that with my colleagues in Rostock. So maybe we can find a solution soon. So with that, I would like to thank a lot of people. Of course, thank you, PRISMAP, for giving me the chance to carry out this wonderful project. It was a really hard project because of the change from TU Munich to Stanford University. So thank you again. Also the colleagues from Belgium that helped me to set up this project also at Stanford. So I know the organization was problematic and also difficult, but in the end, it was. I think it was worth the effort. Thank you again, Charlotte, for organizing everything between PRISMAP and the colleagues in Belgium and Stanford. Thank you again, Uli. I think a big shout out to you, because without you, I wouldn't have been able to continue this project. Thank you to the colleagues also in Switzerland that helped me to get the terbium when I was still in Munich. And of course, my colleagues at Stanford and Munich. And I thank PRISMAP because this was a nice chance for me. When I applied for this project, I basically just finished my PhD. It was still like the COVID pandemic, so there was not much networking going on in my life. So I also didn't have like a big PSMA or FAB compound where everyone is kind of interested in. So 3 years ago, nobody paid a lot of attention to GRPR ligands. It has changed significantly. So fortunately, actually. But 3 years ago, I was really happy that PRISMAP gave me the chance, and I learned, I got to know a lot of people that work on these rare nuclides, and I became more visible, I would say, for the community, and for that I thank PRISMAP very, very much. And I will continue to pursue an academic career. I see my future in Europe, so maybe for the next meetings I can also be present. So thank you again, PRISMAP, and everyone who helped me to set up this project.